Hi, and welcome back to In the Mess. Today we're going to be talking with a couple of recently graduated post-foundation doctors and learning a bit about how to navigate the portfolio and assessments component of being a foundation doctor. Hi. So, you're familiar faces on the channel, but for the benefit of people who might be joining us for the first time, can you let us know who you are and what you're currently up to?
So I'm Kirsty, and I'm one of the clinical fellows in intensive care at Aberdeen Royal Infirmary.
And Andrew, and currently I am a SHO locum and a kind of equivalent to FY4, I guess.
Good. So you've both fairly recently been through the foundation program within a couple of years, at least, which is a bit more recently than I have, it must be said. No comments. Yes, the aging man at the table. So what's in a portfolio from foundation? What are the kind of the key headings for the sections that you need to populate over your time?
Yeah, so there's quite a few in them. So first of all, it'd be forms, and then that's going to be all your sign-offs that you want to do to show, skills that you're developing in the wards, how you're managing patients, and then discussions you're also having with consultants and registrars about patient plans. There'll also be a section on your curriculum, and then that'll also be your personal development plan. So that'll be the aims that you should really be ticking off as a foundation doctor, so your key curriculum coverage. And then also for yourself, how are you going to develop in these 2 years, and what do you set out to do, and how will you achieve that? Amongst that, there'll also be reflections. So I think it's really important now that they're building that into our portfolio that we are actively reflecting and doing that from foundation, because that will be something you carry throughout your career. But there's also a section that will be on your achievements. So, have you done your ALS, your ILS, your prescribing safety exam? Lots of things form in that section too, and that can be really helpful for you building your CV when you're thinking to applying to jobs for specialty training.
It sounds like a lot. How do you get started? Where do you get to grips with navigating it, figuring out what the priorities are, figuring out what this development plan might look like? Where do you begin?
So the first thing is that right at the start of your block, you should have been given a login to kind of whatever system you'll be using in your trust. And my advice would be that it is a lot. It is very daunting. You're trying to wrap your head around a whole lot of other things about how to do the job first of all. And it's very easy to just prioritize that and say, yeah, the portfolio thing can come later. But actually, a lot of the work that you'll be doing, you could have just been ticking off, stuff for your portfolio as you went in the stuff that you're doing. And it's very hard to retrospectively come back and get that stuff signed off. And so what I would suggest is sit down for an afternoon, go through the site that you're using and just get familiar with it. See what's where, what do the forms look like? What information is required? Because once you know all of that information and you're comfortable using the software, it'll be so much easier for you to just send out ticket after ticket after ticket to all the people that you're, doing work with, whether that's, procedures or discussions about patients or examinations or whatever. It's,
Sure.
Be proactive.
Sure. I would say that actually is something that carries through the rest of your training. So I'm almost at the end now of specialty training, have a portfolio as well. It's probably different from the one that you guys have. But the number one habit that I've picked up over the years is, as you've said, once you know kind of what you need to fill in, every single opportunity that you have someone's attention for 30 seconds who happens to have accidentally seen you do something, if you record that, that's another box ticked. So it's just getting into that habit early, isn't it?
Everyone in the hospital, right from, FY1s right the way through to kind of, senior consultants, all of them have had the exact same issues that, you'll be facing with your portfolio and needing to kind of get these things ticked off and signed off. So it doesn't come as a surprise to any of your seniors when you go and say,
some will pretend it is.
Well, maybe, but it shouldn't be. And, you will send a ticket and, but I would always kind of suggest, just ask these people to do it first. Usually if the person, agrees to sign off a ticket for you, they're usually kind of happy that you've done a good job. If they're refusing to sign a ticket for you, or you've not had anything back from them for a while and you've sent a few reminders, probably best just to move on and try and get a ticket from someone else. It may be that they're just caught up and too busy to do the form, but it's usually not a good sign if you've kind of been waiting and waiting and waiting. So always send out far more tickets than you think you'll need.
Totally. Yeah, overshoot. So what are the types of assessment that you're going to need to populate for a foundation portfolio?
So there'll be quite a few of those, and I think sometimes it can be a bit of a puzzle as to what falls under each. So collectively, they'll be known as kind of supervised learning events, and that's to be someone more senior to you. Most likely for a foundation doctor, they'll be wanting it filled in by a registrar or a consultant. But again, that's dependent on the kind of role that you're taking and what you're covering and what you're doing. So firstly, there'll be case-based discussions. So that'll be a patient that you've managed. You'll come away from the patient and you'll talk about their care. You know, what are you wanting to do next? Or you want to get investigations? What does that show? If that shows this, what will you do? And that's to have a discussion around that patient's care. And normally that happens with a registrar or consultant. You can then do things such as mini KEXs. So that's a bit more proactive, involving the patient this time. So that'll be somebody that comes with you and watches you speak to that patient, take the history, and also examine them as well. So that's how they kind of differ. You'll also get things that are to do with your procedural skills. So that's really good when you can get, you know, advanced nurse practitioners, physicians associates, people that do this day in and day out. They can come and watch you, you know, do a cannula, do a VBG. So there's a lot of diversity in the skills that you can do. And I think it's really good to think, what can I do? You know, there's lots, you know, when you're kind of an FY1, you know, doing an ECG, doing a cannula, the things that you would do every day on your job. It's just nice to have that documented somewhere that you are really good at that, actually. And then I think when you're a foundation doctor moving into FY2, you know, if you've got a job like critical care where you might be doing an arterial line, it's good to show that development in your own procedural skills. So it might be that you do that supervised and you record that on your portfolio, but the next time you're showing progression because you're going to do one independently.
And coming back to that, some of the you know, the DOPS, so the directly observed procedural skills that you're getting signed off, some of those are core skills that you need as an FY1 to complete your, you know, provisional, you know, your training and get your full registration. So I think, you know, at the moment when I went through, it was 15 core skills, and it included stuff like, you know, putting in a cannula, taking bloods, blood cultures, male-female catheterization, IVs, and, you know.
So some things haven't changed.
So I think quite a lot of things haven't changed, but actually, you know, they are the kind of the basic skills that, you know, all of us probably will be doing on a day-to-day basis. But, you know, it's very easy to get towards the end of a placement and realize I have done, you know, 24 of these procedures, and not once has anyone actually come perhaps and supervised me doing them, because it's a skill I already am competent at. But the whole point of these they're directly observed. So, you know, you do need to get somebody to come and literally watch you doing that skill to make sure that, you know, you are doing it safely.
Right about this moment, we had some uncharacteristic technical difficulties and had to spend 20 minutes setting up all the cameras all over again. Instead of subjecting you to that, here's some shots of what the cat was doing. I had a leading question.
You know what I mean? Something like
So before literally every camera died and we had a 20-minute interlude of saying #content while Tim fixed everything, I was going to ask you, how do you know, where do you find out what's essential and what's extra? Because everyone always says you should document as much as you can. Every single time you do anything, it's a learning opportunity. And that is true for your training. But there's also a reality whereby there are some things that if the box isn't ticked at the end of the year, it's going to be a So where's the list of essentials and how do you keep to that? And how do you know exactly what your like minimum requirements are that you need to demonstrate by the end of each year?
So at the start of each year, your foundation school will actually send you an email that will contain all that information, because you're working towards your ARCP, which will be the following year, most likely in the June. So they'll tell you the link that will go to your ePortfolio page where there'll be a list of the key things that you need to get signed off. A really good example of that will be what they call mandatory learning. So you'll be expected to do 30 hours, which is core learning, and that'll be provided by the foundation school. So that'll be your weekly teaching. For some health boards, that's an hour every week. Some might do it that you get 4 hours a month for one day that's scheduled off for all your foundation doctors. But there'll also be an additional 30 hours, which is non-core, and that'll be that you have to physically make that up yourself. So that could be, you know, webinars that you watch online through a college. It could be a podcast that you listen to. It could also be, you know, a BMJ paper. So you kind of have to be proactive yourself with how you make those hours up, and that's something that you really want to get linked into early on.
So is this show foundation learning?
I'm going to say yes.
There you have it.
It's clinically relevant.
There you have it. We are...
Like and subscribe.
We are now...
So you all always
in
have
the
a 2 hours long
foundation
hour.
curriculum. You smash the subscribe button because we are your learning outcome. There you go.
But it's one of, and the whole point of this is to have like a wide variety of resources you're pulling from. So I think if it might have changed, but there was for a while a maximum number of kind of online kind of for the benefit of anyone listening without video, Kirsty just got attacked by a moth.
I think it was actually a daddy long legs, but
Totally
it's like just
harmless.
legs everywhere.
Thought it was part of my fringe.
So there was for a while like a maximum number of hours that you could have of like e-learning that you could log as part of that. So, just make sure the UK Foundation Programme website has a list of all of the things that you need to get signed off. So just at the start of the year, go on there, write everything down, put a box next to everything. And then as you go through the year, you can just start ticking stuff off, and it'll allow you to like see an overview of what you've still got to get. And you target those things sooner rather than later.
There'll be curriculum coverage, and that might be slightly different, but the premise that will form is they're speaking about higher learning outcomes. So the first will be you as a doctor. That'll be you showing your skills and competency, but also that you're compassionate, that you understand mental health, you know how to deal with people's social circumstances. The second will then also be how you are day to day. So, how do you interact with the MDT? What are you like to work with? And do you have an understanding of what they do as well? And then the third of that will be about how are you going to progress as a doctor. So there'll be 3 main topics, of which underneath there'll have expectations that you need to tick off. So if you think about it that way, it then becomes quite easy to understand what you need to do to achieve each.
Great. Quick fire round. What is a CBD?
So it's a case-based discussion, but it is what you make it. I could talk to walls, and if you think about it, you have a lot of discussions every day about your patients. So if you're someone who on your day-to-day job, you interact with your consultants, your registrars, your senior nurse in charge, if you're willing to have these conversations, sometimes you can, a CBD is your job and it's about speaking up. So you might have just came up with a really good admission plan for a patient. That is a case-based discussion. If you're able to answer questions about, so what are you looking for in that x-ray? Why are we doing it? Or why are you giving, the furosemide? What are you hoping to achieve? Is that a good thing? What's that going to do? If you've been asked questions like that, that's showing your development as a doctor and how you're thinking as a clinician. So, it's not about being cheeky. It's about saying, any way that we could actually put that on my portfolio and you could give me feedback for how to make that better. If you're saying it's for your own development, everyone's kind of willing to help you. You might find that some clinicians might link it to a paper or say, okay, that was good, but could you go read up on that? And then, send me it and I can have a read of it. So I think it is about sometimes speaking up and also owning the work that you're doing. And rather than getting yourself worked up, because I would get so nervous about trying to find the correct patient. But mainly it's just the people you're seeing every day.
It can often just be like a condition that you've not seen before, and that you've basically needed to go away and learn something either from colleagues or from reading in a textbook. That's a prime kind of thing that you can use as a case-based discussion. Mention it to your senior, go away, have a read about it, and then come back and have a discussion with them, and they will kind of quiz you on your knowledge and will kind of help plug some of those gaps. It's there as a learning opportunity for you as much as anything else.
It doesn't have to be something you're already really good at.
Exactly.
What's a mini-kex?
So mini-kex again is something I think we all kind of, I don't know how many of my mini-kexes have been true mini-kexes, but that's meant to be you assessing a patient. So taking a history, examining them as to what's clinically appropriate, but that's meant to be supervised. So someone's there to do, to be there with you to make sure that your history taking skills are thorough and, your examination is appropriate. You're listening to heart sounds, you're examining the abdomen appropriately. And that's something that should be observed.
And what about ADOPS?
So directly observed procedural skill. So any procedural skill usually that falls out with your core procedural skills. So any additional procedures that you have been involved in that don't form the kind of the main 15, and that can be again kind of what you make of it. It may well be skills that you were taught in med school. It may not be. It may be sort of job specific skills. We talked about in one of the vascular podcasts about doing Doppler ultrasound. That was one of my DOPS for my FY1. It wasn't something that I knew particularly well how to do beforehand, and I was taught how to do it, and I got to the point where I was kind of happy enough, kind of at least provisionally going and doing it, and that was something that I got signed off. So be creative with it.
Good. And what happens if there's something that you really need to get signed off and you're really struggling to get the opportunity to do that, either because there isn't a suitable patient, or the patient isn't giving consent, or nobody's free to watch you? What are your tips and tricks?
So I think off of that, everything that they're asking you to do for your portfolio should be accessible within your job, but there are circumstances where that's just a bit more difficult. I think rather than getting stressed, it's again about being creative. So for example, if you need to do a female catheter, that can be quite hard to find on the ward sometimes. So a good way to do it is, if you're on a surgical ward, would be to approach the patient that's going to theatre, explain and gain their consent. And that way then you could go to theatre and do the catheter there. I think sometimes you do have to find ways of doing it, if that's going to, A&E to a clinic where people are doing lots of bloods, where people have the time to watch you or, to give you feedback. Sometimes you will have to go out your way to get it. And I think that's kind of expected in your job.
Yeah, I think female catheters can be quite a tricky one. I think it's one that probably most people struggle to get signed off. And I think part of it comes from the fact that the nursing staff are very happy to go and put a female catheter in, whereas not all of them will have the training to do a male catheter. And so as a result, you'll quite often get called as a junior doctor to come and put a male one in, and it's very easy then to get that signed off. But if, female catheter is something you're struggling to get signed off, then, mentioning it to the team that you're going to be working with, for that day or that week, that, there's a couple of skills that you're needing to get signed off in your portfolio. And, if these opportunities present themselves, could you kind of come and find me? Yeah, that's certainly the best way to do it. And doing that earlier in the block rather than later. It's very hard if you've got 1 week left and you've got none of your portfolio signed off. It's very difficult to do it. So the best advice I can give is just get started early. If you can aim to have all of your stuff signed off, the minimum stuff signed off within the first kind of half, or at least first 2/3 of your block, you're laughing. You can really actually just enjoy the second part of your placement and not worry about the paperwork admin side of things.
Is the actual process of linking all of this stuff and putting it all on the portfolio arduous? I think you've got it in front of you, Kirsty.
Yeah, so it can be, and linking is completely right. So what they want you to do is, after you've done an event, you have to link it to these higher outcomes that have been sent by your foundation board. Again, just as Andrew said, it's taking a day to sit down, blocking off an afternoon when it's coming to the end of your block, and just linking it in. It's not hard to do, but you can get stressed. You can overlink things. You kind of have to sit and work out, what ticks off my box for dealing with end of life care, or, speaking to the greater aspects of social care, some of the kind of more harder to cover curriculum areas. So it just takes a little bit of thought. I think if you definitely do say, I always said, 2 weeks before my supervisor meeting at the end of a block, I would sit down and sort my portfolio out, because then it's one less thing to stress about.
Yeah, and if you've read that list of all the different bits of the curriculum, that you need to get linked, if you've read that earlier in your year, then it's very easy that, once you've done a teaching on, diabetes management or something, you can link that to chronic illness, and you can start kind of like linking all of these kind of bits up early and as you go, and that does help. And it is I think a better way of doing it than sitting down. I made that mistake of sitting down kind of towards the end of the block. I kept putting it off and off and off, thinking it'll be easier to just sit down and do it all. But what I ended up finding was that actually there were still bits of the portfolio that I didn't have anything linked yet. And so then it was scrabbling a little bit more towards the end to try and get it. So if you've been a bit more proactive, then you can prevent a whole lot of unnecessary stress.
I think also, if you're struggling, just say, you'll have someone who is allotted to your foundation school who's to deal with that. So always just shoot them an email, say, how am I meant to fill this in? Do you have any information? Most of the time they'll just signpost you to the foundation board, their online website, but that's got a lot of useful information as to how you can deal with these kind of issues as they crop up.
Any last minute advice?
Don't get stressed about developing the clinical teacher. I think that's something people get really worried about. So that's to really push you to start teaching, students, other doctors that you work with. That can be something, if you're in a job where they do weekly junior doctor teaching, that would be you giving, a 10-minute presentation on abdominal pain, and then getting your supervisor to sign that off. So again, that will have to be somebody that's there to see you give the presentation. But again, that can be very achievable. It doesn't have to be you presenting at a conference or anything like that. If you have done that, fantastic. But the day-to-day works of just teaching your colleagues can also count for things like that.
Yeah, I think above what we've said, I think we've given a lot of kind of useful advice that I kind of wish I'd known before we started. But I guess one thing we'd maybe not quite touched on is certain bits of your portfolio will need to be signed off by doctors of a minimum grade. So just make sure that you're not caught out by that, and double check. Some of the mini KICSs and CBDs do need to be one of the kind of more senior trainees. Other things, such as some of the DOPs, can be kind of junior trainees or allied health professionals. So just double check that you've got the right kind of skill mix signing off your documents as well.
It's the same as a lot of things in medicine, isn't it? We assume that what's expected of us is a superhuman effort. In reality, all you're doing is documenting your ability to do the day-to-day job. And you do that all the time. So just a case of finding someone to put it down on paper.
Absolutely.
I hope that was really helpful for you. The portfolio is often a sort of tricky surprise, but in reality, it's documenting the stuff that you already know how to do. So I hope this was helpful. If there's something that we missed, don't forget to leave a comment. And as always, like and subscribe so you never miss a thing.
And so that you get your extra learning adjectives.
And so that you can use this as your actual CPD.
Yeah, absolutely. See you next time.